To all of you.
Morning.
It's my pleasure to welcome you in this last box case. I'm Xavier Monnet ISICEM. In Paris, and it's my pleasure to present this lecture with my friend Dr. Sheila N Myatra. I will let her present herself.
I already did, actually. I'm Sheila N Myatra, professor of intensive care, working at the Tata Memorial Hospital in Mumbai, India. Happy to be here.
And she is the president of the big Indian Society of Critical Care Medicine, much bigger than the European one. So, welcome to this case. We will discuss the way we use the tests of preload responsiveness. I will make a very short introduction on the theory, and then we will review with Sheila the ways we do these tests in practice. I first disclose my conflicts of interest with Palchan Medical Systems and with Baxter. And Sheila?
I have no conflict of interest, yeah. So if you're not sure about something, ask me.
It's all about, as you know, fluid infusion and the way we assess this Frank-Starling slope. I will not review what you know already. In some cases, fluid infusion with the same increase in preload leads to a positive or a negligible increase in stroke volume or cardiac output, let's say, is the same because heart rate doesn't change that much during fluid infusion. And the problem is that you don't know the slope of this curve. In a patient, it's not written on his face. So, is that an important issue? Yes, definitely, because if we give fluid to patients who do not need fluid, it's fluid overload and deleterious fluid overload. That justifies testing the efficacy of the drug before giving the drug. And all the tests of preload responsiveness are based on the same principle, that it's a dynamic assessment of the slope, in fact. The principle is easy. You change preload in any way you have, or you observe any spontaneous change in the preload, and you assess the change in cardiac output, stroke volume, or any surrogate. And today, as we will see, we have several ways to assess preload responsiveness, and in fact to change preload. You can do that with fluid itself, passive leg raising, or by manipulating the ventilator. And you know that during mechanical ventilation, each increase in intrathoracic pressure decreases preload. So during ventilation, preload varies from cycle to cycle.
Interrupt you here. So how many of you assess fluid responsiveness before giving more fluid to a patient? Can you raise your hand? So many of you, really? Okay. So assessing fluid responsiveness is not important during initial resuscitation, right? When you have a patient who comes with you in acute circulatory failure with hypotension, fluid resuscitation is one of the first few things. So it's not an issue for initial resuscitation. It's more after you give a large amount of fluid, you've already resuscitated this patient, and the blood pressure is still low, the lactates are still high, but the CVP is also high, and you're not really sure, you're in a dilemma, and someone would say, how does it matter, just give some more fluid? But like Prof. Monnet said, that if you're not a fluid responder, not only will it not cause any benefit because your cardiac output is not going to increase by giving more fluid, but it can actually produce harm in some patients. And that's why we have to be very careful. So the testing doesn't come when a patient just comes to you. It comes after the initial resuscitation. Am I right?
Nevertheless, it happens quite rapidly that fluid responsiveness disappears. We have reviewed a case yesterday, perhaps some of you were here, where we saw that it disappears after 1-2 hours. After 2 hours, it has disappeared in 60% of septic shock patients that were preload responsive at the beginning. So initial fluid loading depending on absolute hypovolemia, but quite quickly after assess preload responsiveness. Otherwise, you will give fluid to patients who do not need fluid.
Yeah, especially when it's not very obvious that they are, it's very important,
Some tests mimic a full fluid challenge. Some of them use the ventilator. And we suggest that we will review them and perhaps assess them in terms of degree of demonstration, reliability. Is it easy to perform or not? Can you do that in many patients? And a big and important issue, can you do that without a cardiac output monitoring, a sophisticated cardiac output monitoring.
Just one comment. Why not then just give a fluid challenge?
Yeah, it's a first
Why not,
very important
because
question.
if you really want, when you say your fluid responsiveness, you mean that by giving fluid, the cardiac output of the stroke volume is going to increase by, say, more than 10%. So why not just give a fluid bolus and look at the increase, and then you know whether this is a responder or not.
Which
What's
volume
wrong?
you mean, Sheila? A fluid bolus of how much?
About
500?
500 ml. What's recommended is anything more than 4 ml per kg given over about 10 minutes. But what's the downside of this approach? Why not? Anybody?
So I don't know if the patient is a responder. Let's just give fluid and we will see.
You can test if he's a responder. So why not?
What's the drawback of that?
Yeah.
If he or she is not a responder, you've already given the fluid and may have done more harm.
Absolutely. You can't take that fluid out, right? So that's one of the downsides, but it's a good way to test. It's a good way to assess fluid responsiveness.
And that's a very important point for the first of the tests we will review, which is the mini fluid challenge, because it's exactly the principle of this test. You give just a very small amount of fluid initially. And then, of course, it's very easy to do. You just give fluid and assess the answer. So the principle is that I give a small amount of the total fluid bolus, 100 and 150, assess the response, and it will tell me what will be the rest of the fluid of the response. You understand? And so, of course, if it's negative, it's not a big problem because I gave only a small amount. Okay? The way to do that is very important. You want to comment on that,
Yeah,
Sheila?
I just said the volume you give is less, but to assess the response, I think you would use echo, right? You'd use VTI. It's a very small volume, so you have to be an expert echocardiography. So I would say, I would not call it easy, really. I would say giving that 100 ml is very easy.
Principle is
But
easy.
I am not very good at detecting that small difference in the VTI. You have to be a real expert echocardiography. The other argument would be that you're not doing just one. Though it's a small volume, it's not 500 mils that we're giving. If you repeatedly do it, you're still giving volume to this patient. That might be quite a bit if you're doing it 3-4 times, right? In a non-responder. Sorry.
And indeed, you need something that very precisely measures cardiac output. If you have the most precise techniques you have, it's pulse contour analysis. You can trust even a 1% change in cardiac output, but of course it's expensive, sometimes invasive. If you use echo, echo is not that precise. The smallest change in VTI you may trust in a patient when you make a measurement and you come back and do another one, it's a 15% change, so it's quite so. If you do a mini fluid challenge, let's do that very cautiously. You ensure first that cardiac output is stable, for instance, that VTI is stable in this patient. Then you use, of course, a real-time measurement of cardiac output, not thermodilution. You infuse 100 or 150, but very rapidly. And what we do in practice is that we use syringes. 3 syringes of 50 in order to give that in a very short time. And then, of course, you assess the response. If you use echo, my piece of advice is to keep the probe on the patient. And in such a way, the precision increases a lot. Of course, you keep the how do you call that, the echo beam, right? The echo beam in the LV outflow tract. So do not measure, tell the nurse, okay, give 150, come back 15 minutes later and assess the response. That's not precise. And that's a big issue because it depends a bit upon the studies. Let's say that 5-10% increase. Let's say if cardiac output increases by more than 10%, you are sure the test is positive. But some studies reported lower thresholds. Of course, the larger the change, the more confident you are. Okay? But it's quite the point. And I can only insist on that. So different thresholds reported, applicable in many patients, but it requires a precise measurement of cardiac output. Do not repeat it too much. as said by Prof. Myatra, okay? Do not repeat too much, otherwise in fact, you give 500 or 1 liter of fluid.
Xavier, sorry, but I would say easy to perform. I would put it as well. Sorry.
You're right.
I'm not an expert.
No, yes, you are, but except if you have, for instance, pulse contour analysis
yes,
in such a way, you just have to look at the screen, but it's only a minority of the patients. So you're right, it's either green or red if you use echo. I do agree, of course. Let's move on to passive leg raising. So you know the test, okay? The principle, likely you know the test, right?
How many of you perform passive leg raising in your unit? Oh, wow, a lot.
Let me insist on 2 points regarding the test. So you know the principle. Roughly, it's 300 mL of blood that you transfer, but it varies from a patient to another. Okay, the way you do passive leg raising is quite important to consider. First, you know you might start at a 45, at least 30, 45 degrees. If you start in the horizontal position, you will not mobilize the volume of blood that is in the large splanchnic compartment. And that's an issue, because a large part of the effect of the test is due to this splanchnic blood volume. So you easily understand that if you start horizontally, then you do not use this blood.
So it's pelvic, splanchnic, and from the lower limbs, all giving you about 300 ml of
in total.
Approximately, yeah.
By the way, in very responsive patients, you can see that just lowering the trunk increases cardiac output. It's quite, not funny, but interesting to observe. Use a real-time assessment of cardiac output. Thermodilation is not good for that. You can use echo, the same problem with reliability. If you use echo, again, I suggest that you keep the probe on the patient. It's much easier, and somebody else performs the passive leg raise. Don't take the heels of the patient. You just mobilize the electrical bed. That's better, because otherwise the patient wake up, etc. Suction the patient before, if he or she is ventilated, because otherwise he will cough during the test, and the test may have very much false positives. Of course, in this position, you measure cardiac output. You put the patient back in the semi-recumbent position and check that cardiac output returns to baseline. Because if the patient is very unstable, you will see that cardiac output does not go back to the same value.
Absolutely. This is the reason I asked how many do it, because he's told you the precise technique of doing it. Move the bed and not the patient. Start from semi-recumbent. Wait for the cardiac output to come back. Use real-time cardiac output monitoring. All these are very, very important things to keep in mind while doing the test.
And that's the first point I wanted to insist on. It's true that it's not a very easy test to perform. You easily understand that. That's why I say it's easy to perform. A mini fluid challenge, in theory, it takes less time and you don't have to move the patient or anything. By the way, it is feasible in the OR, while of course passive leg raising is not feasible in the OR. So I'm sorry, there was a movie showing you how we do in our unit. This is a bed in our unit. So don't worry, Sheila, I have checked all the videos. It took me 15 minutes. So it should work. Yes. So you see, we start in the semi-recumbent position. So what we do usually, we first lower the back of the patient and then increase the legs. Of course, be careful that the patient does not extubate during the test. Otherwise, it's a winning trial in the same time. And you see here, it's a continuous measurement of cardiac output with pulse contour analysis. So in this way, it's very easy to do, much easier than with echography. So you see that now the patient is not really at 45 degrees for the legs. It's not possible with our beds, but 30 might be fully okay. Perhaps
Sorry, what is the advantage of this test? What's the beauty of this test? It's like an auto fluid challenge, right? And you're mobilizing a good volume. It's 300 ml is not less, right? It's more than 4 mils per kg. And it's completely reversible. What are the limitations of doing this test? Any limitations? Can you do it on every patient? Not in the OR, of course, but in the ICU, yes. If you have brain-injured patients, neurotrauma patients, orthopedic surgeries, patients who need immobilization, you may not. These are just some of the limitations, but you need to keep this in mind.
And on the contrary, you can use it in patients with, without ventilation and with cardiac arrhythmias, which is not the case with pulse pressure variation, etc.
And also intra-abdominal hypertension, right? I mean, yeah.
Yes, there may be some false negatives in case of high intra-abdominal pressure. I think it needs to be a bit confirmed because there's only one good study. Even if we did it, but I think it should be confirmed.
I think one of the biggest advantages of passive leg raising is it's the only test that doesn't depend on heart-lung interactions. So it overcomes all the limitations with the tests using heart-lung interactions like low tidal volume, spontaneous breathing, arrhythmias, open thorax, all that which are limitations of the other tests. Passive leg raising can, is not dependent on even spontaneous breathing or, like he said, patients with arrhythmias.
Another limitation of the test is that you cannot do it just with pulse pressure. Pulse pressure, and we discussed it in previous cases if you're here, is a rough surrogate of stroke volume. It is determined by stroke volume, but a rough estimate. And so you need something that measures cardiac output directly. So echo is okay, pico, Vigileo, or you can use some newer but also more interesting ways like a decrease in pulse pressure variation, meaning that you don't need any cardiac output monitor, you just need an A-line and an arterial curve. Likely it needs more confirmation. There are less studies than direct measurement of cardiac output, but you understand that it would be a nice way to do. We also published some studies showing it's possible with a perfusion index, the amplitude of plethysmography. I think it requires more confirmation from other groups, but if confirmed, that would be a nice way because you just need a pleth sensor.
So how many of you use it with cardiac output monitoring or with echo?
Echo.
Okay. So many of you do it, but you're probably looking at arterial using it with an arterial line, right? So it's not that reliable.
So if you only have an arterial line, please rather look at PPV than pulse pressure. And the worst value to look at is mean arterial pressure because it tends to remain constant in any case. So pulse pressure better than MAP, PPV better than pulse pressure. And there are quite a number of studies, no, Sheila?
Yeah.
Okay. Possible without cardiac output monitoring in some patients. Just a few words on pulse pressure variation and stroke volume variation. You know the principle of PPV, right? It's what we said. In fact, during tidal ventilation, preload changes cyclically. So if the patient is very stably ventilated, each change in the intrathoracic pressure will change preload. Then it's just assessing the effects of this change in preload on pulse pressure. And if pulse pressure changes to a large extent, and we have many studies that tell us the real threshold, 15%, then you know that it is positive. So you see it's easy to understand in this way. So it's really a good, it's purely related to preload responsiveness, to the slope of the curve. But the problem is that there are many, many situations when you cannot do that.
So what are those situations? There are some limitations of this test, though they've been extensively studied. They're one of the most widely studied pulse pressure variation and stroke volume variation, especially in perioperative period. But what are the limitations of this test? Anybody? Yeah.
First, spontaneous breathing, even in intubated patients. Second,
Spontaneous breathing, yes.
arrhythmias. Low tidal volume, likely below 8, likely.
So arrhythmias, open thorax, anything that will be interfered with heart-lung interaction. But the most common complication is low tidal volume. And we use low
Indeed.
tidal volume in almost all our patients today, not just in patients with ALI and ARDS, but also patients with sepsis, and even those of you who are from anesthesia, I don't know. Even in the operating room today, we're much gentler on the lung when we use about 6 to 8 ml per kg. So very good test, works very well at 8 ml. But is not reliable at tidal volume less than 8 ml per kg idle body weight.
So everything is green except the applicability. And that's the big point. In our practice, we have a study on that. It's in 80% of the ICU patients in shock that you cannot use PPV.
Yeah. And
A much better way to use PPV, I'm sorry. If the patient is ventilated at 6 mLs and
you get a high value. So that's a very good question, because the problem with the low tidal volume is the tidal volume is not, all these studies have largely been done in post-cardiac surgical patients, and the tidal volume is not high enough to elicit these changes. So when you use a low tidal volume, what will you get? False positive or false negative? What should you get? You get false negative values. That means the patient would be a fluid responder, but you may get a value under 12. So your question is that if you're using 6 ml per kg and say my pulse pressure variation is 18 or 20, so this is already a fluid responder with the low tidal volume. The problem is that if the value is 6 or 7 and you're using low tidal volume, then you don't know whether this is a fluid responder or not. Am I right, Xavier?
you're right, but in this case you have a nice way to use PPV in any case, which is the tidal volume challenge, to change the tidal volume.
Yeah. Okay. So I'll talk about that. Yeah. So this is a test that we developed in our unit, the tidal volume challenge, and not just with PPV, also with stroke. Sorry, not just with PPV, but also with stroke volume variation. You could use this test, but studied extensively with PPV. The beauty of pulse pressure variation, using this test with pulse pressure variation, is you don't need continuous cardiac output monitoring. You don't need a continuous, you just need an arterial line, which you would already have in a patient with acute circulatory failure, right? If you're treating a patient, so you have an arterial line, and for many years I didn't know that you could get PPV automatically. You just use a simple software that you can get PPV as a value, so you have a dynamic index that you can get on the monitor, and you can perform a tidal volume challenge. So this is the paper that we published in critical care medicine. So what you do is you just transiently increase the tidal. So it's a test that works very well at 8 ml, but doesn't work when the tidal volume is lower. So our hypothesis was that why don't you transiently increase the tidal volume from 6 ml per kg to 8 ml per kg, and then look at the pulse pressure variation. That was the hypothesis. But interestingly, when we studied it, oh, you've put the video already. How do I go back, Xavier? Sorry, yeah. So interestingly, when we studied it, it was not the value. The value at 6 was very bad. At 8, it was better. But it was the delta, that is the difference between the value at 6 and 8, that was a better predictor of fluid responsiveness. And I'll just show you very quickly how you could, do this on the monitor. So here you see the arterial line, and the pulse pressure variation is 8.
Automatically measured by the monitor.
Yeah. And this 270 is a patient has 45 ideal body weight. Now I'm increasing the tidal volume from 6 ml per kg to 8 ml per kg, which becomes 360. And then just look at the monitor. Here the pulse pressure variation is 8. When you increase the tidal volume, you see an increase in pulse pressure variation. I hope you can appreciate that. So it's increased from 8 to 10, okay, and 10 to 13. You do this only for 1 minute because we don't want to increase the tidal volume for 8 ml for more than a minute. And then, you see it's increased to 15. And of course, after 1 minute, you must bring this tidal volume back to 6 ml per kg ideal body weight. So very simple to perform. And your patient should be, sedated and even paralyzed, but not necessary to be paralyzed, but should not have, should have stable ventilation. And it's interesting because when you bring the tidal volume back, the pulse pressure variation also starts falling. So if you remember, we started at 8. And after 1 minute, it went up to 15. 15 minus 8 is 7. This is more than the cutoff value is 3.5 for pulse pressure variation and 2.5 for stroke volume variation. And now it's been extensively, this was a proof of concept study that we did in our unit to develop the test. Now it's been extensively studied in other centers. We have more than 10 trials, and now there's a meta-analysis establishing its reliability in with use with pulse pressure variation. You can also use it with stroke volume variation. You can use it in patients with low compliance and many other indications. But this is a very simple test that you could do, which doesn't need continuous cardiac output monitoring. And improves the reliability of these tests.
I like the example because you can see it even visually on PPV, on the PPV signal, that it almost doubles the variability of pulse pressure varies.
And
it's better to measure it.
Many people have an arterial line, but they don't use pulse pressure variation. So it's just a software you have to call most monitors have it, just get it on your monitor. Yeah.
A study has been published a few weeks ago in Critical Care, reviewing all the studies, as said by Sheila. Perhaps we need some more studies to define the threshold. What is your point of view on the threshold to consider to say the test is positive?
There are individual variations, but by and large, in most studies in a meta-analysis, as well as this study that was done with PPV, the cutoff values that they got were close to between 3 and 4. So again, in all these tests of fluid responsiveness, let me tell you one thing. It's not only the fluid responsiveness, the degree of fluid responsiveness is also important. Like you said, you have, say, a 20% increase in cardiac output. This is very reliable that it's a fluid responder. But there's always a gray area, like even for pulse pressure variation between 8 and 12 is like a gray area. So when it's a gray area, that's when you should combine it with other tests, including your clinical assessment, of course. And you shouldn't rely just on that one test. Am I right, Xavier? Because
Absolutely.
you have to, use in conjunction your clinical assessment along with various tests that can be useful at different time periods during your assessment.
Variability of the inferior vena cava is very popular, but just in a word, these are the least reliable indices of fluid responsiveness, the least reliable indices. And it's demonstrated by many studies, including a large study. The area under the RAC curve is low, and likely because many factors influence that reliability of the IVC, the first being the intra-abdominal pressure. In addition, many people miss that it has the same limitations as pulse pressure variation, minus arrhythmias, plus intra-abdominal hypertension, which is so frequent in our patients. So, the least reliable.
Least reliable, but the beauty is it's very simple to do.
Yes, but
it's not much, and you can, even before you put in lines, you can make a quick assessment, but the reliability is questionable.
yes, if it's simple and not reliable. Another test that is very easy to perform, and the last one, is the end expiratory occlusion test. Have you heard about this test? How many of you use that? End exp test. The patient is ventilated, so at each time it decreases preload. You understood? I stop ventilation for a few seconds at end expiration. 15 seconds. So preload during this short time will increase, will reach a maximum. I just click on the ventilator and expiratory hold. And if it is long enough and you need 15 seconds, the increase in preload will cross the pulmonary circulation. It will increase the right, but also the left preload. You test preload responsiveness of both ventricles. So it's a way, again, to use the ventilator as the VT challenge, as pulse pressure variation, and it's very easy to perform as the VT challenge. We have now many studies. The test is easy to perform just in a few words. I measure cardiac output at baseline. I stop ventilation for 15 seconds. I measure cardiac output again. And the threshold of positivity is 5%. Very concordant studies. Okay? Questions? Because we come to the end of the list of our tests, Sheila.
But I think the important message is look at the degree of fluid responsiveness. May not be initially, you need not go, be obsessed with fluid responsiveness. Give your fluids, and then the first opportunity that you get, assess fluid responsiveness, especially when you're in a dilemma. When you have gray areas, don't use only one test. No test is perfect. We all each like our test. So a combination of clinical assessment along with different tests together should be your approach when you assess fluid responsiveness.
Especially because of the gray zone, as said by Sheila. So if the value you obtain is close to the threshold, I'm not sure it's positive. I use another test that will confirm or infirm, but use the reliable test.
Any questions? Quick questions?
Rapidly, because we are out of.
Sometimes in monitor that don't have the automatic software for PPV, and I freeze the waveform and measure the maximal, and yeah.
That was what we used to do. But any of these monitors that you have, which can transduce an arterial line, can give you PPV. It's automatic. It's just a software. I didn't know it for 10 years. I was freezing the screen and measuring, and then someone from Philips came and said, "Oh, you want this? We can do this for you." They just clicked a few buttons and I had first pressure variation. And I felt so stupid. So many people use an arterial line and don't use this very useful indice to assess fluid responsiveness, which is a dynamic parameter.
Thank you very much.
Thank
If you
you.
have questions, we can answer outside.